Hi everyone, my name is Rebecca and I'll be giving my presentation on alcoholism and liver transplant. Some background on the issue and organ transplant in general. More than 34,000 patients are awaiting an organ transplant, and specifically for liver, around 3,400 people are awaiting an organ. And organs are such a scarce resource that this number is so high, but there are not enough organs to be allocated to every single person on the wait list. Besides alcoholism, there are many other diseases considered for liver transplant, and these include hepatitis, liver cancers, and acute liver disease. While there are other diseases, alcoholic liver disease is the most common liver disease in the Western world. And this chart shows general criteria for selecting transplant recipients. And if we look at the alcoholism row, the heart, lung, and liver criteria includes that there is no active alcoholism or no current use in order to be eligible for transplant. So this I'll touch on more a little bit later, that in order to be considered for an organ transplant, specifically a liver transplant, that patient must abstain from all alcohol use before transplant. This topic is significant because if alcohol-induced liver disease was not considered criteria for organ transplant, then 50% of patients with end-stage liver disease would be denied transplant since alcohol causes half of these cases. Alcoholism can be considered a behavior or a disease, and the question remains, should liver transplant be allocated to alcoholic patients? Whether or not to provide a liver transplant to an alcoholic patient is the most widely discussed issue, and there are two sides to this controversy. The first side is that if there is a history of drinking, this person is not eligible for transplant, which would mean that this person has a behavior of drinking. And this behavior could mean that there could be a relapse into alcohol post-transplant, making this organ not viable. The second side is that if there is a history of drinking, but this patient has demonstrated recovery, then alcoholism is considered a disease that can effectively be treated. This matters because with so many people on the wait list for a liver, some would consider it unjust to give transplants to those who brought upon their illness by themselves because of alcohol. Organ transplants place a great burden on the healthcare system. The average wait time for an organ is between 150 and 700 days. Since this wait time can be so long, patients need to be monitored and evaluated during this time, and if they get worse, they need to be treated. Transplant operation requires many resources, and these operations can normally last hours. Some of these resources include surgeons, medical teams, and aftercare. Sometimes patients can be placed in the ICU. These patients take up beds and equipment and nurses and other staff. The average charges billed per transplant in 2017 for liver transplant was about $812,000, and this could always vary if the patient faces other complications and needs more care and more intervention. This cost will obviously go up. The thesis statement for my final paper is, due to the scarcity of available livers for transplantation, liver disease as a result of alcoholism should be seen as a disease that can be treated with liver transplant if the recipient has demonstrated recovery, rather than a disease that cannot be treated. There are two main ethical principles in conflict, and those are utility and justice. Utility is the best outcome for all, while justice is treating all patients equally. In order to solve the problem of utility, the supply of organs must meet the demand, and the only way to solve this problem is to have an unlimited supply of organs, which will never happen because there are always people in need of an organ and not enough donors. Even with public support, there still are not enough organ donors to supply the demand for organs. In order to determine which patients will have the best outcome, the issue of alcohol relapse must be addressed. Patients who are less likely to experience relapse will be eligible for transplant because the organ will remain viable after the transplant. Justice for eligibility of transplant for alcoholic patients is an issue because a patient's social worth can be questioned. Since some part of society considers alcoholics not deserving of transplant, some might ask, is it fair to give this patient a liver that is a scarce resource since alcoholism is a self-inflicted disease? If alcoholic patients who have end-stage liver disease are not offered transplant, this will lead to further liver failure, which will lead to death, all because some consider their disease and life less deserving of somebody with a different kind of liver disease. The AMA Code of Medical Ethics states different physician obligations. One of the codes states that a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. This code can extend to the issue that alcoholism should be treated just like any other liver disease and not be discriminated against because some might see it as a self-inflicted disease. The AMA also includes sections for organ transplant and procurement. Except in situations of directed donations, ensure that organs for transplantation are allocated to recipients on the basis of ethically sound criteria, including but not limited to likelihood of benefit, urgency of need, change in quality of life, duration of benefit, and, in certain cases, amount of resources required for successful treatment. This code is taken directly from the AMA Code of Medical Ethics. This makes it clear that recipients must meet sound criteria in order to be considered for liver transplantation. Hospitals have different regulations in treating alcohol-induced liver disease and end-stage liver disease caused by alcoholism. To qualify, patients must undergo an abstinence period or a treatment program. These usually vary by hospital or transplant clinic. To resolve the controversy surrounding whether or not an alcoholic patient should receive a liver, hospitals have implemented a 6-month alcohol abstinence period. If completed and a liver is available, the patient is eligible for transplant. If alcohol is found during this 6-month period during a screening, the patient is disqualified and taken off of the list, and the liver is given to someone who is higher on the list or who has completed the program. To help relieve the high cost of organ transplants, the Healthcare Finance Administration agreed to fund liver transplants for alcoholics if the patient meets the requirements and maintains sobriety before their transplant. With proper screening and support, alcoholic patients have a 71% survival rate after transplant. Since there is a generally high survival rate for alcoholic patients who have received a transplant, more hospitals should implement alcohol addiction units. These units provide a support system for the patient to maintain sobriety before and after their transplants. Alcoholic patients are more likely to stay away from alcohol if they are followed by a team to monitor their use. If alcoholism is treated like a disease instead of a behavior, more patients will be eligible for transplant and there will be better outcomes because it will be seen as a disease that can be effectively treated. This chart shows that patients who are treated with alcohol addiction units have a lower percent chance of relapse after transplant than those who did not use an alcohol addiction unit. Liver transplant should be granted to alcoholic patients because there is no statistically significant difference in mortality rates in patients with a history of alcohol and in those without a history of alcohol. Actually, patients with viral cirrhosis have a higher chance of disease recurrence than an alcoholic relapsing after transplant. Transplant teams have no medical or moral reason to refuse liver transplant to a patient with a history of alcohol because this patient can be closely monitored and have a good support system to facilitate the best outcome. Since there is no statistical difference in patients with and without alcoholic liver disease, and alcoholism can be monitored and controlled with a good support system, patients with a history of alcohol use should be eligible for liver transplant if they demonstrate recovery before transplantation.